Hi, class. This is the second lecture in our discussion of childhood language disorders, Chapter 7. And we are going to launch into describing in much more detail some specific named language disorders or disorders that impact language and talk about their causes, risk factors, hallmark characteristics. So the first one is specific language impairment. Um, this is the one that is a significant impairment in language that cannot be attributed to any other causal condition. So, again, that would make it a primary disorder because there's no other disorder that's causing it. And I want to remind you that if we were talking about a child of school age, and this was a significant issue to be impacting academic progress, that it would also probably be labeled a specific learning disability in the area of language, but specific language impairment. So the defining characteristics or how we distinguish it from one of some other language impairment. Well, first, these kids have typical hearing skills. So we know that it is not due to a hearing impairment. We've tested that, we've ruled it out. The second is there are no obvious neurological, motor, or sensory disturbances or disorders that we could say are causing this language issue. So it's none of that is causal. It is definitely an impairment all on its own. And interestingly, specific language impairment cannot and should never be used as a label prior to a child's third birthday. It can't be accurately diagnosed, and that's because of that possibility of late talker. Before the third birthday, what we're seeing that might look like delays in the development of language or a potential disorder in the development of language could be that sort of late talker phenomenon. So before the third birthday, we should be very careful to not say this is a specific language impairment. This is a very diverse group of kids. They don't all certainly present with the same symptom mix or describing characteristics. So we're going to talk right now about hallmark characteristics. So what is pretty typical of this group, and you'll see that the first one addresses that diversity. The first hallmark characteristic is that they have inconsistent skills across different language domains. What that means is they may have some good ability, for example, in the pragmatics area, the social skills. These are kids that understand social relationships, or some of these kids, and they make good attempts at the things like the give and take of conversation, but they may have real difficulty with the form of the language. So they may be using inaccurate syntax or word order, or have some difficulties with phonology that are really impacting language. Or this is a child who may have some pretty decent grammatical skills but have a limited vocabulary. Or they have a combination of just skills across the three domains of content, form, and use, which is why they are not all going to look the same, and they're going to be a very diverse group. The second hallmark characteristic is, as a group, they tend to have a history of slow first word acquisition. So these are the kids that when we ask the parents, when did they say their first word, we might hear, oh, they didn't say any real words until 18 months or 2 years. If parents don't remember specific times, by the way, when you're asking that question, then you rephrase your question to, well, did it concern you? Did it seem to be late to you when they said their first word, or did it feel like it was right on time? These kids tend to have a bit of a delay in the acquisition of first words. The third characteristic is they tend to have what we're going to call word finding problems. Which means they're having difficulty finding the right word at the right time. Now, the term word finding problems is one you'll hear in discussion of adults with language issues due to neurological issue. So I want to explain it a little bit right now. With a child who seems to not be able to find the right word at the right time, it could be because they have not yet acquired that word. And they just are groping around in there to find a different word to use for their intention. However, it could be that they just can't find the word that they want quickly enough. And we kind of null that out with single word vocabulary testing, and we'll get to that in the chapter on assessment. But what the evidence of this is, in children is that they tend to depend on a lot of filler words or junk words. And I use the word junk words with the kids because they don't understand the term filler words. But for example, if I ask a child, what does your mom or what does your dad do for their job? I may hear they're a worker. Okay, I'm a worker. But what do they actually do for their job? And the child may have no word for that. Or if I say we've just come back from winter break and their family celebrated Christmas, and they say, oh, did you get any Christmas presents? They may say, I got all kinds of stuff. Or we did a lot of things. So they're using those junk words or filler words because they cannot use the more specific word. The fourth characteristic is these kids tend to have difficulty with grammatical production and comprehension that begins in toddlerhood. Now, as I said, up in hallmark number 1, you may have a child that has some pretty decent use of spoken grammar or syntax, but as a group, they tend to have some weakness in this area. It continues through school, which is problematic because in school we're learning to, read for understanding, and we're learning to write, and we need to use good grammatical form. And where I typically see this the most, and the research bears this out, is in verb tensing. So understanding when to use the correct tense for the verb, or even being able to use verb tensing beyond that present tense. And then some kids, especially the really young ones, come in with difficulty with pronouns. And even today, in our current conversations about pronoun use and preferred pronouns, we still teach kids pronouns because pronouns are referential in their reading, and they will likely be that way in their writing too. And kids need to learn how to use pronouns in a correct way. But often kids, especially the really little ones that are coming in from preschool with language impairment already identified, have difficulty mixing up the pronouns. The fifth characteristic or hallmark of this is problems with social skills and behaviors. Even those kids whose primary area of weakness within this disability is not social skills and not pragmatics, they may still have difficulty in their functional social engagements. And a lot of that is because of the language issues. So the not being able to ask questions of peers, or not being able to participate in the give and take of conversation with peers. So they will present as having some weakness in social skills. And then the sixth characteristic is this tends to persist over time. About 50% of kids identified with specific language impairment as preschoolers or into school age will have that weakness persist into adulthood. So for those kids, we're still providing the same kind of therapy, but what we're also providing is compensatory strategies and accommodations to help them be as successful as possible through adulthood. Some causes and risk factors. Well, we've already said that this is the one identification that we have no known cause for, nothing we can identify. We do know, as with many other things, there is likely some genetic tie because we know the research shows that 20 to 40% of these kids have a parent or another very close family member, a sibling or a grandparent, that also has some form of language disorder. That's called a predisposition. And predisposition is not enough to be causal. Predisposition is something about the child or in that child's life that is unchangeable, that is somewhat static. So a family history of language disorder is static. We can't change that history, right? But predisposition alone cannot be causal. There are other risk factors, though, that could make a child more developmentally fragile, whether or not they have that predisposition, and those are called precipitating factors. These are things that happen to or that change in a child's life. So, for example, things like sensory deprivation, that child we talked about previously with the chronic middle ear infections, that's a precipitating factor. That's something that could have been, perhaps even was, controlled for in that child's life, but it still happened to that child. Other things like postnatal exposure to toxins or undernutrition as an infant. Those are all things that could have, should have been controlled for, maybe even had been controlled for, but they become a precipitating factor. Now, add those on top of a predisposition, and we're now increasing the odds that this child is going to have some kind of language impairment. So, moving on to autism spectrum disorders. Autism spectrum is an umbrella term that describes a variety of developmental conditions that are all characterized by significant difficulties with social relationships, communication, repetitive behaviors, and overly restricted areas of interest. Now, previously, before the DSM-5, when the DSM-5 came out, the diagnostic code is autism spectrum disorder, one code. In the DSM-4 and earlier, there were actually 4 very specific disabilities or diagnostic codes listed under that umbrella. We're not going to discuss all of them, but you will definitely see those terms in older literature because the DSM-5 has not been out for even a decade yet. So the first of those was autism, and then there was childhood disintegrative disorder, pervasive disorder, and Asperger's syndrome. I'm sorry, I didn't have those in my notes anymore, so I was trying to remember them. They were 4 characteristics, and they all had, 4 diagnostic codes, and they all had slightly different characteristics, but they all contained these issues with social relationships, communication, repetitive behaviors, and overly restricted areas of interest. So the decision was made to call it a spectrum disorder. And by spectrum, it means that on one end, it's very, very mild, and then it ranges across that spectrum to very profound and impactful. So defining characteristics for all of the spectrum disorders. Your book says that we identify spectrum disorders in 1 in 88 children, or 1 in 88 persons. That's not current information. I looked it up, and the current CDC statistic that was published in 2020, so is probably from research from 2019, is 1 in 54 children are now identified with autism spectrum disorder. And we can talk about that in class a little more if you would like to, why that is happening and why it's not happening. But we're not going to take the time right now in the video to do that. Just know that it's much more common than it was previously thought to be. We do know it also has a strong, potentially genetic component. It does tend to run in families. When we say that, by the way, what it means is that in genetic research, a specific gene or a specific coding of chromosomes cannot be identified that says, oh, here's the one that causes autism. But we do know, looking backward through research, that autism spectrum disorders run in families. And I can tell you, and probably anybody who has worked with these kids as frequently as someone in the public schools or in a specific private practice that works with kids with autism spectrum disorder, it's pretty obvious. It is not uncommon for me to get a referral, and when I meet the parents, I'm like, I understand a lot, because it's not uncommon for one of them to at least present with some of the characteristics of the disorder. Many, many more boys than girls are diagnosed with autism spectrum disorder. And traditionally, it was believed that when girls were diagnosed, when girls were affected by autism spectrum disorder, they were much more severely disabled. There are challenges to that assumption now going on, and I think that they're very valid. Research is showing that girls go unidentified at a much higher rate than boys because um, their symptom mix, the way they present, is very different than boys. So it's not unusual for a girl who gets a referral to not be given that diagnosis, to be given a different diagnosis, like a specific language impairment or even ADD or ADHD. Whereas in a boy, it's very easy to make the diagnosis. Well, it's easy to make it in girls too. It's just that girls present very differently. They have a different symptom mix than boys, so they're not typically identified as quickly, if at all. So again, I have in my notes now is where I have it written. Under the newest edition of the DSM-5, adopted in 2013, there were the 4 distinct categories: autism, childhood disintegrative disorder, Asperger's syndrome, and pervasive developmental disorder. Again, they're all now just labeled autism spectrum disorder. The one that you will see singled out the most often at this point is Asperger's syndrome. And let me spell that for you because I'm humored by how often I see it spelled really funny ways. Asperger apostrophe S. It's a possessive label named after Hans Asperger, who was from Austria. So, in order for a diagnosis of autism spectrum disorder to be valid, the following conditions must occur. The first one is it must emerge in childhood. Now, I'm sure some of you at least have heard of someone who, as an adult, says, "Wow, I just found out I have autism. I was just diagnosed with having autism." That's absolutely valid. That's not the problem. But in order for them to receive that diagnosis, someone has had to do a very good job of taking a case history back to their childhood and can see that there were characteristics that emerged in childhood that would have led to that diagnosis in childhood. So it must emerge in childhood. It's not something that as an adult you can say, "Wow, I just got autism." No, you might have been just identified, but it emerged in childhood. Second, it must impact everyday functioning. This is not something that comes and goes. It's not something that can be 100% controlled for by environment. It impacts everyday functioning in some way. The third is it must include problems with social communication and social interaction. That is a hallmark characteristic. And then the fourth, it must include restricted and repetitive patterns of behavior and or interests. So, for example, of repetitive patterns of behavior, the one most commonly associated with autism is echolalia. Echolalia, the repeating of words or sentences over and over and over again. However, other repetitive patterns of behavior can be things like rocking or tapping or excessive blinking. It's not the same as obsessive compulsive disorder, but those repetitive patterns of behavior sometimes can be one of the things that makes a differential diagnosis a bit of a challenge. And then as far as the restricted areas of interest, I can tell you, again, as someone who's been doing this kind of diagnostic work for a long time, when a parent comes into my office and we're talking about what does your child like to play with, and I hear trains or dinosaurs, they'll only play with trains or they'll only play with dinosaurs, I almost don't even have to go on with the assessment. Now, obviously I do, I'm being sarcastic, but those are 2 really common areas of interest. For girls, it's usually something like horses or princesses. But again, restricted areas of interest. Now, all children have some area of interest that they like more than others. I have one grandson who just absolutely loves dinosaurs, and I have another one who absolutely loved trains when he was a little bit smaller. But it wasn't an obsession to the point where they wouldn't play with anything else. These kids, since we're on this topic, they also tend to not play with the toys in the same way. So they may have dinosaurs, they may know them all absolutely by their real dinosaur name. They don't want to call them something else, and they'll get very upset with you if you refer to the Brontosaurus as a Stegosaurus. But they also don't play with them in interactive ways. They tend to line them up, put them in lines, separate them by categories, whatever category catches their attention, their color, their height, their what they eat. Same thing with the trains. They want to put them on the floor or on the track in a line, and sometimes you'll notice that they don't run them around making train noises. They lay down on the floor so they can watch the wheels turning. They might know the names for all of the cars. As adults, this might, I'm not kidding you now, go down to, for example, since we're not all at Cal State Fullerton, but many of us are close, go down to the train station in Fullerton, and probably on any given day of the week, you will see one or two adult, usually it's men, down there, and they'll have a little notebook in their hand, and and they don't get on a train, but as the trains come in the station, they're recording what the number of the engine was and how many cars were attached and where it's going, or did it come to the station on time. It's not unusual, because that restrictive area of interest is there. So the 4 presenting conditions that I just described can and do vary in severity from child to child. I've seen kids on both ends of the spectrum and everywhere in between, where it's really, if they're at the very high end, it's even hard to diagnose that they're on the spectrum, because in many ways they're so functional. Um, I'm sorry, I'm just trying to look ahead in my notes to see if I said this so I don't repeat myself. Nope, I'm not going to say it yet. But there's a huge variety in the presenting characteristics. So the discussion of difficulty with social interaction. They may have difficulty with things like impaired nonverbal behaviors. So they don't realize that their own nonverbal behaviors are interfering with communication. So, maybe they're looking away from their communicative partner and seem to be paying attention somewhere else. That's a nonverbal behavior. They may very well be paying attention. And by the way, we do not rate goals for eye contact anymore, because we have found that eye contact for someone with autism is a very anxiety producing situation for them, which is probably why they're looking away, but they're still attending. Those nonverbal behaviors are probably communicating lack of interest in peer relationships. And again, sometimes that is the truth. Sometimes they really, truly do not have any interest in peer relationships, but other times they do. They just don't know how to demonstrate that. One characteristic of folks on the autism spectrum is called mind blindness, which is having very little awareness of the feelings or the needs of others. In other words, not being able to take the perspective of another person. And we have a really fun little task for assessing this. Now, it's just a tiny little snapshot. It is certainly not diagnostic all on its own, but it's called the Sally Ann task. And it's cartoon strips, and there's 2 little girls, Sally and Ann. And Sally has a basket with a cloth that covers it, and Ann has a box that can be closed. And in Sally's basket, there's a ball. And in the next cartoon strip, Sally leaves the cartoon. She walks out, and then Ann goes over and takes the ball out of Sally's basket and puts it in her box and covers it back up and puts the cloth back over Sally's basket. And then Sally walks back into the cartoon strip. And you ask the child, where will Sally look for her ball? Now, if the child says she'll look in her basket, we know they have probably pretty intact perspective taking, because Sally was unaware that the ball was moved. Where would she expect to find it? She'd expect to find it in her box. But if the child's answer is, in her basket, excuse me, if the child's answer is she's going to look in the box, We usually then follow that up with why, and the answer we will get is because that's where Anne put it. The child is not taking Sally's perspective. The child thinks that Sally saw everything that they saw and thought everything that they thought. So Sally ought to know that the ball is over there in Anne's box. So that's just one example of how we would begin to assess that. A next area, again, with these folks on the spectrum is this impairment of communication skill. And this can go from very mild to profound. So we have some folks on the autism spectrum disorder who are completely nonverbal, some who are nonverbal, but we find can communicate with an alternative means. And we also have some who have incredibly beautiful content and form of language. Their only communication impairment is in that social realm, and we'll talk about that again in a moment. Some use very idiosyncratic language, in other words, language very specific to them. Like they'll only use specific words to define things or to talk about things and not use the variety of language we would anticipate them to use. Or they use that very repetitive language, echolalia. I had a student many years ago I believe he was in fifth grade at the time, who had very good language skills, but whenever you would ask him about, a television show or a movie, he talked in scripts. In other words, he would say, "Coming soon to a theater near you, there's this great new movie," and he'd go on to tell you about the movie. So he'd remember the introduction that he'd heard on television or on a movie preview, and he always used that. So that's kind of an idiosyncratic language usage. And then again, to the restricted and stereotypical behaviors. We've talked about those. I don't think we need to talk about those anymore. The Asperger syndrome was the one that I wanted to come back to. Asperger syndrome under the umbrella of autism spectrum disorder. These folks have very good communication skills in terms of the content and their form of language. In fact, it is so good that Asperger nicknamed these folks little professors. Their language skills were excellent. However, their language in the area of use of social pragmatic language is significantly impacted, and that is where it impacts their daily life. They have substantial problems with social interaction, and they also often show those restricted areas of interest in some idiosyncratic behaviors. So autism spectrum disorders, we've covered it all, and I'm going to say, and I'll say it probably a number of times, immunizations are not causal. And if you want to talk more about that during our Zoom meeting, that's great. I'm happy to talk about that. The next piece we're going to talk about is intellectual disability. This is a condition of arrested or incomplete development of the mind, of cognitive ability, characterized by impairment of skills across development and manifested during that developmental period. Now you'll hear it, I talked about this once before, you'll hear it labeled different things: intellectual disability, mental retardation, developmental delay. Intellectual disability is the term that is used internationally, so the most commonly used term. Mental retardation, I discussed that in a different conversation. It's not politically correct because of the negative connotation that's been more recently applied to it. However, the semantics of the term are very relevant and very good descriptively. And then developmental delay, again, not commonly used because it implies that development will continue happening until the child catches up, and that's not the case. It is 1% of all school-age children in the United States are identified with some level of intellectual disability. The book uses the term cognitive adaptive disorder. That's a really great term used to explain, because it's used to explain the limitations in the cognitive development or the intellectual processing and the come along impact on adaptive behaviors. Adaptive behaviors are those skills we need for daily living activities. So the ability to demonstrate self-direction, to make decisions for yourself about health and safety, to have self-care skills, all of those things that you would need to achieve some level of independence. Both intellectual ability and adaptive behaviors must be identified as weak or absent or very delayed in development before we start talking about things like severity. It's not just enough to look at that IQ. We have to look at how that IQ is impacting the adaptive behaviors. So, the diagnostic criteria. Um, the first is there's a limitation in intelligence that includes difficulty with things like reasoning and planning and problem solving, abstract thinking, comprehending complex concepts, all of that learning skills, the things that we think of as a person needing for achievement progress in school. The second is limitations in adaptive behaviors, so the activities of daily living. Um, the social skills, the practical skills, self direction, health, and safety. So it is truly a cognitive adaptive disorder. As with other disorders, when we're talking about severity, you have to look at cultural and linguistic factors. So, in this case, in the child's microsystem, their individual close family, how is that limitation in intelligence impacting their participation in that microsystem? Then, in the mesosystem, their neighborhood and their community, how is it impacting there? And then in the macro system, how is it impacting their participation in society overall? I would love to take some time and tell you about two young ladies I know. Well, they're not so young anymore. They're probably both in their 40s. They are both Down syndrome. They both were identified with the typical intellectual disability that comes along with Down syndrome, but they are both, as adults, because of lots of great intervention, very mild in this classification because of their great adaptive abilities. One of them, um, when she was in high school, she went to the same high school that my boys went to, but she was a little bit older than them. But when she was in high school, she was able to, during her class time, she went to school half a day. The other half a day, she walked across the street to the local elementary school in a few blocks, and she was an aide in a first grade classroom because she had adequate enough abilities to, one, do that completely independently, the walking, leaving school and walking across the street and eating her lunch and taking care of herself. And then she also had the academic abilities to be able to sit and listen to the kids practice their reading or to score their single digit addition and subtraction papers and help them with that. And this was a young woman with Down syndrome. One of the other young women, I knew her from a church setting, and she was a deacon in her church setting, a church that happens to have a huge ministry outreach to children and adults with disabilities. And when a new family would come on the church campus, she was kind of their tour guide around the church campus. She also worked on the bereavement team, so preparing for like family receptions and stuff after funerals. And she lives still today, lives independently. Now, does she have social workers and her own family that check in on her? Yeah, she does. But she lives in an apartment and she has some level of independence. And I've seen her often out in the community before all this COVID shut down. I'd see her out shopping with a friend or at the movies with some friends who have very typical cognitive abilities. So in those cases, those young women were very mildly impacted. 95% of those classified as having intellectual disability are classified as mild to moderate. Thankfully, that number is very high. Their language skills are usually approximate with their cognitive abilities. So if we're doing standardized testing and the child comes out with an IQ in the 70s, chances are their language standard scores will also be in the 70s. They typically show delays in those early communicative behaviors. So the first word acquisition, the ability to point to request, the things that we look for in development. Um, In this case, the path of acquisition of the language milestones tends to be exactly the same as for a typically developing child, but again, just at a slower rate. And at some point, it will hit a cognitive ceiling and not go above that. So, for those with very mild impairments, that cognitive ceiling may come when language becomes more abstract or much more complex. New language skills, though, can continue to emerge well into adolescence. Usually, comprehension is a stronger skill than expression is. And it's considered a static disability. And what that means is that there's steady progression or steady progress. It's just at a slower rate. There are some conditions of intellectual disability that are progressive, which means they will show regression and loss of skills over time. These are usually caused by metabolic disorders such as hypothyroidism or Rett syndrome. Rett syndrome is a genetic syndrome related to or has symptoms much like autism. And it is one of the things that I will tell you is much more common in girls than boys. 30 to 40% of people born with intellectual or identified with intellectual disability is non-causal. We don't know what caused it. The other 60 to 70%, there is some causative incident that we can identify, either the genetic chromosomal abnormalities such as Down syndrome, or their anoxia, lack of oxygen at the time of birth, maternal ingestion of toxins, so moms who either take prescribed or non prescribed drugs during a pregnancy. Again, sensory deprivation, autism can have a come along of intellectual disability. I'm going to stop right there because this has gone longer than I hoped it would, and we will pick up with brain injury in our next video.